All right. Well, it seems to me that I'm probably the only thing standing between you and the Memorial Day holiday, so I better be good, talk fast, and be a little bit funny, okay? Okay. I'm an old lady, and I can get cranky. Scott, don't you dare walk out, okay? Um, I have worked with Scott for a while, but he took the lead on this initiative. And all I can say is, wow. I mean, we worked and we worked hard. And I would like everybody, there were 25 different agencies, and I know that they're not all representative here, but anybody who was on the committee, would you please stand along with Scott, and would you please humor an old lady and give them a round of applause, because they have worked hard. Stand up, John, stand up. August 3rd, 2016 will mark 30 years that Arlene Benzick and I saw the first 2 patients in what became the HIV program. So she and I have done this for 30 years. There are days that I've gone home after clinic sessions and I have cried my eyes out. And there are days that I went home and I put my head under the pillow and I said, you know, this virus is just too sophisticated. Science has just run away with the world, and I'm never going to come out again. I'm just going to put my head under my pillow and stay here for forever. And then there have been days when I rejoiced, and today is a day that I rejoice. So I can't thank you all enough for being here. Now, I have told you a little bit about the Pennsylvania Mid-Atlantic AETC, so that's fine. I don't have to do that. And again, this multi-agency task force. So we used to call it multidisciplinary. Now we call it interprofessional. So this is a group of just about every discipline you could think of in medicine that came together and worked really hard. So there were 3 main goals, and that became the 3 different sections of the website: general information for potential PrEP users. And this is the brochure that has been published. You can request lots of them. I would love to come to your agency and see that you have them in a big folder somewhere in your waiting room and in your clinical rooms and maybe in your bathrooms. This will be a great brochure, a great way to get the conversation started. So this will give us general information, particularly for PrEP users. You'll also find in your handout today a wonderful CDC handout, and I would keep this back in your clinician's room where you see the patients so you could begin the conversation in the actual clinic setting room with them, okay? So you'll find all of those in here and in that general information for potential PrEP users. That's the place you're also going to find a list of current providers, and there's about 10 listed there now. And this is an ongoing website that's being developed, and things are being added and changed. So you really need to put it in your smartphone to check this at least once a month to see what's going on, okay? And the thing I would encourage you to do, whether you like me saying it or not, I kind of like to encourage you, if you decide you're going to be a PrEP prescriber, to call the consortium and get your name on that list that you're one of the providers. But if you need help, if there's someplace you want to refer somebody, the list of providers is there. As I said, we've worked really hard to get permission from those providers to list their names, their numbers. And within one agency, you might find 7 different doctors, so there's real potential there to find some help. The second part, which I think is most important that I kind of like to really emphasize today, is information for physicians and potential prescribers. So that section 2 is really the section I want to hit hard. Section 3 is news and review, and you'll find a lot of new things there, and that will be good, and that's probably what you want to check once a month. It also gives you information about upcoming conferences, how to get more information, and when this advisory council meets. So if you have questions and we're going to meet, you could tell us. Also, new to be listed to this list, it's not there yet, okay, but after hearing the discussion this morning, I really want you to know that there's going to be a list of Walgreens HIV specialist pharmacies will be added, okay, and that's going to be both under Section 1 and Section 2 soon. So when I hear you all talking about needing help, don't let these people sit around and not be busy because we're busy. Let's call these people and make them do those referrals and do that paperwork and get us those dollars that we need, okay? So that's coming soon. Now, we know as of December 2015, there were 3,434 people living with HIV. So that means 1 out of every 275 people will be positive. So I often wonder when I go out to a ball game or something, there's about 300 people. I wonder how many people here are HIV positive. Now, that's the way my mind works, okay? But then look at these gross disparities, look at these numbers, look at where we need to work, and it's what we've heard all day. So African Americans, 1 in every 97, the N of 2,067, 1 in every 568 white people, the N of 1,051, and Hispanics, 1 in every 345 with an N of 241. This is collaboration in Delaware. I can call public health. I can tell you what your prevalence is if you need to know, because I know who to call in public health to find out exactly what your prevalence is and wherever you live, your zip code or your county or your state, okay? So public health does a fantastic job of counting these numbers and making sure that everything's accurate. We have kind of a little saying we say in the ETC that, dollars will follow numbers. So you need to make sure you've got your numbers, you've done your homework, and that it's accurate and you've got a way to back it up. So we still know that every 9.5 minutes in the United States, there's a new case of HIV infection. And this screams to me that primary prevention is not working. We're doing a great job once we find the people, and we're finding them too late. Let me tell you, in Delaware, we're finding them too late. So primary prevention is a major problem. Think of all the 9.5-minute segments of time you and I have been together today. All the people that were negative when we started this conference and all the people that will now be positive at the end of the day. That's mind-boggling to me. I love that Dr. Smith has already introduced the strategy, because I thought I would be so old and cranky I wouldn't be able to stand up here anymore, or I would be dead before the United States got a national strategy. And look what happened. In 2010, President Obama, after having over 1,800 meetings and documents, was able to publish the U.S. national strategy. I almost passed out. They got all these different people to talk together: housing, substance abuse, mental health. They all sat down at tables and talked together. It was unheard of. And so they actually devised the national strategy. So the United States will become a place where new HIV infections are rare. And when they do occur, every person, regardless of age, gender, race, ethnicity, sexual orientation, gender identity, or socioeconomic circumstance, will have unfettered access to high-quality, life-extending care free of stigma and discrimination. I love this slide. I'll probably never take it out of my slide set. I was one of those early educators that got access to this slide. It says, you can call the White House, and here's the White House number. So I gave you that. You didn't know you're going to leave here today with the number to the White House, did you? It's much easier to Google this one, okay? But that's one of my favorite slides. So from 2010 until 2015, our feet were, kind of held to the fire that we had to produce. We had milestones. We had to make reports, whether it was good news or bad news. We needed to report what we were finding. And last year, 2015, those first results came in. Based on that, as we've heard from an earlier speaker, we've added a fourth goal, which is achieving a more coordinated national response. So reducing the number of people who become infected, increasing access to care, reducing those health disparities, and now the more coordinated national response is a part of the national strategy. So one of the days that I wanted to put my head under the pillow and never, ever, ever come out and play again was the day I got this slide. The green is a beautiful T cell, which is just about ready to be lysed, broken open, destroyed, and forever lost. And the red is the budding virus. The virus reproduces 10 billion viral particles every 24 hours. That's why we need to get people on medication as soon as we find they're HIV positive to slow down that reproduction of that virus. Even people who are very, very ill will generally continue to produce about 2 billion T cells every day. They are naive T cells. They have no memory. So our patients are at risk all the time of mumps, measles, chickenpox, flu. Our patients have to be really, really careful because the memory cells are wiped out, and those new cells that come have no memory. They're naive. They put them at risk. 10 billion viral particles every day. If we can prevent this in any number of patients, we're doing a good job. So if we look from 1985 till 2004, we see the yellow triangles are the AIDS-defined cases. And in 1993, CDC actually revised the case definition and added some additional, 3 additional case definitions at that time. And you can see that by that time, we were getting better at trying to come up with care plans and ways to treat patients, and we were beginning to see antiretroviral therapy, even though it was monotherapy with ACT in the early days. So about 1993, when that case definition changed, Delaware was actually second in the nation for 2 good months. So we've always had high numbers, and we've generally, unfortunately, always been in the top 10, which I don't like at all, and we live on the I-95 corridor. And as we just heard, if you see the blue squares there, the number of deaths rose and rose and rose until 1995. In 1995, we got protease inhibitors. We began to pass combination antiretroviral therapy. And 2 years later, we had proof that C. Everett Koop knew what he was talking about. If you take your medicines, they will work. Medicines only work if you take them. So there was a dramatic drop in the death rate, and I think we can do better with that. And it was combination therapy. I really think we can do better. I was talking to a few people in the hall earlier this morning. There was 1 week in the clinic we had 8 deaths. Most of the nurses that started the clinic were what I call high-tech, low-touch. We were ICU nurses. We had all kinds of machines, and we could run anything. But we never helped someone die, and now we have flipped our roles, and now we were helping people die, and we weren't high-tech. And bereavement overload hit the staff. And when we talk about workforce development and taking care of ourselves, this is something that had a major impact. So we went from that week where we had those 8 deaths to 1 death in 1 year after combination therapy. I thought the statistical team had gone too steep for a while, and we went back and said, please look at that again. So that was the impact that it made. It was dramatic. So what has continued to increase and cause problems is prevalence. Prevalence is increasing because we're keeping people alive, they're living, they're doing extremely well, and it's also because we are not doing a good job with primary prevention, and I think PrEP is going to be wonderful. AIDS.gov actually has a blog that says that they believe 185,000 new infections can be prevented by 2020 if we really gun up and we really are able to implement PrEP. 185,000 new infections would be wonderful. It would be wonderful. I did a lot of maternal child early on, and I love my women and children, and I love the fact that I can tell you now that perinatally infected infants are growing up, getting married, and having kids of their own. And if you'd have told me that was going to happen back in 1986, I'd have thought that you were absolutely crazy. So again, from 1985 until 2004, you can see that perinatal infection was about 25%. I never dreamed I would stand in front of an audience and tell you today that it's about 0.8% to 1% or even less. So the Pediatric AIDS Clinical Trials Group, the PACTG 076 study, was the study of pregnant women and giving them antiretroviral therapy. Women are never involved in research, let alone pregnant women. So this was a real hallmark study. It was supposed to go on for years and years and years, but the Data Safety Monitoring Board came along and said, we have to stop this study because, look, there's a 67.5% reduction in maternal child transmission by just giving the one drug, ACT, to pregnant women. They stopped that study. They went open label. They began to offer voluntary testing to women. And just by saying, we want you to do this, 93% of the patients in Delaware immediately said yes, and we're up to around 95 to 98% of all pregnant women going for voluntary testing. There are some researchers that I work with, especially out of Maryland, who believe that the one-time antiretroviral therapy is an emergency as pregnancy, so we want to find them. So between screening, voluntary screening, and passing antiretroviral drugs, you can see there's been a 95% reduction in pediatric maternal to child.